It is live, sir. You can start now.
Chaitanya, go ahead.
Yes, sir.
Chaitanya, you can start.
Sir, okay, sir. Good morning, sir. Good morning, Samantha, sir. Good morning, Ghansham, sir. Thank you for giving me this opportunity to present in this HICS live webinar series. My topic is about humanizing intensive care units. My presentation will be in the following pattern. What is the exact problem, definition of humanizing intensive care unit, patient perspectives, family perspectives, healthcare workers perspectives, strategies for humanization, plan for humanizing ICU, digital transformation and technology, benefits of humanization, challenges faced during implementation of humanizing ICU, holistic care. Coming to ICU, the clinical scenarios of intensive care unit patients are complex and are characterized by the potential for organ failure and death. Patient condition can shift rapidly from improvement to deterioration and even vice versa. ICU patients may experience discomfort, panic, anxiety, unreal experiences, and dreams. It has been noted that 70% of ICU survivors experience physical, cognitive, and mental health related problems or societal disturbances after discharge, known as PICS, post intensive care syndrome. Similar experiences have been reported even in the relatives of the family and parents in pediatric ICUs. This is called PICS-F, called post intensive care syndrome family. Shifting of focus of care towards more human centered care can to an extent reduce the negative impact of ICU admission and subsequent symptoms of post-intensive care syndrome and post-intensive care syndrome family entities. Coming to humanization, there has been a scoping review has been done, but as per now, there is a lack of consensus on definition of humanizing ICU. In the scoping review, 2 of the 12 papers drew on Royal Spanish Academy's definition found to make someone human, familiar, and affable. The remaining 10 papers involved around 3 main themes: holistic care of the patient, general attitude of professionals towards the patient, and organizational trait towards all subjects of the healthcare system. So, humanizing ICU care can be defined as a holistic care as a general attitude of professionals towards patient and relatives, and an organization ideal encompassing all subjects of the healthcare system. What exactly a patient is feeling is described as Wilson M. et al. In Critic Care 2019 edition, considered to be a horror in ICU experience. In the midst of trying to correct organ failures, clinicians may neglect to carefully consider what the patient is experiencing. Patient may be on the brink of the death, may be unable to speak, he might be stripped naked, having strangers entering the room, simultaneously doing things to their bodies without explaining to them, having tubes inserted into their orifices, their arms getting restrained, hearing a disorienting bedside alarms whose meaning lies beyond them, to be poked all while families torn away. Together, along with these facts, patients often do not have a memory or understanding how they have ended up in this horrifying situation. So, what the patient might be seeing in an ICU, there may be minimal natural light within the ICU, so they may be unaware of the day and night. They are surrounded by lights, monitors, waveforms, seeing other patients who are completely unfamiliar to them. They may be facing hallucinations, delusions, misperceptions. What the patient might be hearing: loud alarms, machine beeps, staff conversations. These noise may impact psychologically and physiologically, which the impact may be lasting temporarily or even permanently. Patients' perspectives include these patients may be sedated, unable to communicate due to intubation, other medical interventions leaving them vulnerable to feelings of helplessness. There is a loss of dignity and dehumanization leading to profound emotional and psychological damage, erosion of trust, violation of relationship between the patients, families, and healthcare providers caring them. These are all dehumanization aspects according to patients' perspectives. There is a loss of identity, loss of ability to communicate, loss of ability to advocate for oneself, loss of control, loss of self-respect, loss of privacy and modesty, moreover, sometimes purposeful shaming or mocking. Coming to families' perspectives, sudden admission, unexpected nature of ICU admission leaves the family members wide variety of emotions like stress, anxiety, fear, and sadness. These feelings may be exacerbated by the critical condition of their loved ones and the unfamiliar and high stress environment of the ICU. Families often feel shocked and they are unprepared for the rapid changes. The more sicker the patient, like severe accidents, major surgeries, life threatening illness, the more will be the emotional impact on the family members. The emotional and psychological strain faced by the families, they often confront intense fear and emotional distress, which can influence their decisions in the ways which may contradict the patient values and wishes. The management of end of life situations can lead to conflicts among the family members and healthcare staff. This in turn leading to burnout syndrome among the ICU practitioners. Coming to healthcare workers' perspectives, ICU professionals work in high stress settings, frequently exposed to emotionally charged situations, excessive workload, understaffing, all together may lead to burnout syndrome, compassion fatigue, moral distress. Often they feel torn between the need to maintain a clinical detachment and at the same time the desire to connect with the patient on a human level. Moreover, in a country like India, where there is diverse difference in language, religion, culture, and socioeconomic status, which in turn can create barriers for effective interaction, these barriers further lead to misunderstandings and feelings of isolation among the patients and families. A humanized ICU requires a multidisciplinary healthcare team where not only intensivists, nurses, physiotherapists, speech therapists, clinical pharmacists, psychologists, social and spiritual workers, and even the presence of the family within the ICU altogether brings significant advantage not only for the patients but for the families and for the healthcare staff. There is a paradigm shift towards humanized care. The elements include a shared decision making, compassionate care, patient centeredness, support to the patient and relatives to be connected while they are within the ICU. Some of the strategies which can be applied, including redesigning the ICU environment, enhancing emotional comfort, digital transformation, and applying technology benefits, engaging families in care, holistic approaches. HUICU Humanizing ICU project have suggested strategies for humanizing ICU. They have 7 strategies together put. Strategy 1, where they have included open door ICU policy, where accessibility is provided to all irrespective of the timings. Proper communication within the team, with the family, with the patient. Well-being of the patient always takes top priority. Physical, psychological well-being with respect to the patient autonomy and environmental well-being, nighttime rest. Caring of not only patient, caring of the professionals by identification of occupational burnout is an important thing. Post-intensive care syndrome, early identification, prevention, management is also included in the strategy. End-of-life care includes protocolized end-of-life care decisions, accompaniment, and multidisciplinary discussions. Humanized infrastructures where patient privacy, comfort, orientation, maintaining patient distraction to an extent are considered as strategy 7. Interventions for prevent patient privacy through the use of folding curtains, screens, curtains, and other separation methods between the bays can to an extent make privacy possible. Patient environmental comfort, daily exposure of images of nature has found to have significant recovery from stress. Pilot studies have found virtual skies on the ceilings of their beds have found to have beneficial effect, leading to physiological relaxation, modifying the negative subjective experience of being within an enclosed space. Coming to natural light, to preserve circadian rhythm day-night pattern, designs with windows to the outside and with mirrors to see outside, substituting the existing lights so that they are programmed to simulate a solar cycle, calendars and clocks so that to prevent disorientation of the patient so that they do not lose the sense of time and date. These are standard light luxus light levels prescribed in an ICU: general lighting, bed lighting, examination lighting, emergency lighting, monitoring lighting. This is a concept of green hanging gardens or hospital garden concept, where hospital green space exposure to the patients and families improves mental health being, reduces anxiety and faster recovery from illness or surgery. Even other studies have found gardens elevate stress in the healthcare workers attending the patients. These are some of the studies where what does the study found the impact of gardens on the nurses, and they have found the emotional exertion has been decreased in the nurses. In the Ulrich quantitative non-randomized control study, where hospital gardens have decreased the stress scores within the healthcare professionals treating. Coming to sound in the ICU, to reduce noise levels as perceived by the patients, ICU rooms should have solutions to improve noise absorption and blocking. The number of alarms should be reduced at the bedside, having an active monitor near the nurse in charge. Where these are all not possible, noise should be replaced with more pleasant sounds for the patient. According to WHO, a noise level of 30 decibels is accepted. Maximum sound pressure is 35 decibels. Even colors and space to an extent help in calming reducing the stress levels in the ICU patients. Accessible space for wheelchairs or beds so that patient can go out in fresh air if their condition allows. Nature helps in restoring emotional centers by stimulating limbic system. Color green in particular stimulates cognitive functions. Need for limiting excessive stimulation, allowing person to develop paying attention to him or herself. Coming to music therapy, this is more like a personalized music therapy or person directed music therapy. It has shown to impact physiological parameters. It has shown to have positively influenced blood pressure, heart rate, and there is a release of endorphins, which are considered as natural painkillers. These effects can contribute to overall well being, reduce pain, and decrease fatigue in the patients. Music therapy, according to a randomized control trial by Chlan, it was found that patient-directed music therapy reduces anxiety and sedity exposures in critically ill patients receiving mechanical ventilator support. Even as research in Journal of Intensive Care 2023, a multi-center randomized control trial found music helps in mitigating anxiety in adult critically ill patients. Even touch plays an important role in an ICU patients. Touch helps in communicating the needs, demonstrates compassion, indicates human presence, allows sensory processing, generates meaning, strengthens connection, calming effect, decreasing anxiety, and it helps in communicating the empathy. Animal assisted interventions have found decreased cardiovascular risk, anxiety, and post traumatic stress improvement. John Hopkins professionals have found therapy animals, particularly pet animals, are effective non pharmacological interventions that help in ICU patients becoming more active and engaged in their recovery. Animal assisted interventions can positively influence the patient outcomes by promoting engagement, reducing emotional distress, decreasing physiological burdens, and improve psychological status. These are all incorporating examples of incorporating animal assisted interventions, their own pets at the bedside within the ICU. Some of the strategies: healing walks despite structural limitations, simply bringing patients closer to the windows or walking few meters has found demonstrated benefits. Healing gardens, animal assisted interventions, personal music therapy has already been discussed. Encouraging patient connectivity by using their mobiles and other devices helps in distracting themselves and communicating with their loved ones and stay connected to their environment. And we have seen all this during the COVID times. This is an example where the patient has been brought near seashore. This is the patient where the elderly lady has been with the oxygen support has been brought outside the building as a healing walk. Addressing patient's perspective, explaining procedures prior to the execution, respecting patient privacy, considering non-medical aspects, always consider the values, preferences, and lifestyles of the patient's perspective. Promoting family involvement, expanding the A to F bundle, liberation bundle by adding GH, gaining insight into the patient, delivering holistic care with a home-like environment, even included I, where interactive environment by using virtual reality and augmented reality can be tried. Introduction of ICU diaries can also be tried. This is a humanized ICU project where this is the patient, this is the patient, these are all patients, but this is not patient-centered care we need. We need a person-centered care where each individual has aspiration, each individual has values, preferences, their own memories, their own personalities. These aspirations, the way they see themselves, their autonomy, their personality, how distinct they are, addressing the patient by their own names includes person-centric care. Coming to families' perspectives, addressing these involves actively engaging families in the care process, providing timely, clear communication among the families involved in the care discussion. Open visitation policy is a flexible visitation policy, allowing family members to visit ICU patients not only strict according to strict traditional visiting hours. This open visitation policy has decreased anxiety, decreased length of the stay, and higher patient and family satisfaction with this kind of approach. There is also an added level of transparency of what is being done within the ICU, along with the sense of collaboration between the family and healthcare providers. Effective communication is a key role. Providing clear and jargon-free information is needed. Engage in difficult conversation. Not only discuss the short-term issues, but also discuss prognosis and long-term outcomes. Skilled communication training among the healthcare providers themselves. Building therapeutic alliances involving family members. always promoting open, effective conversation among the within the healthcare staff, within the interdisciplinary branches, and with the families. German Interdisciplinary Association of Critical Care and Emergency Medicine have given recommendations regarding children visiting ICU. They have given 10 recommendations, and in most cases, children visits have found more beneficial than harmful effects. Children want to be informed and in touch with their sick loved ones. When they are not allowed to visit, they often feel excluded or scared. Most children can handle the visits if they are given age appropriate information. This is a decision algorithm, how to prepare, how to visit, how to do the follow for children visiting intensive care unit proposed by German Interdisciplinary Association. Here they have taken children till less than 17 years of age. Addressing healthcare workers' perspectives, improving the well-being of the healthcare staff through initiatives such as debriefing sessions, mental health support, team-based care models, promoting a work environment helping in clinical excellence and emotional connection, even early identification of burnout, early identification of compassion fatigue, prevention and management of burnout syndrome are components of addressing healthcare workers' perspectives. Coming to examples of dehumanization of ICU on the left side and humanizing behavior in ICU. Dehumanization patient, if you do not address the patient by their name, there is a loss of identity, loss of ability to communicate from the patient side, loss of ability to advocate for oneself. There is no family presence, there is no control, there is loss of respect, loss of modesty, privacy, purposeful shaming and mocking discussions at the bedside near the patient, purposeful exploitation for research. These are all dehumanization practices. Whereas humanizing behaviors include unrestricted family visitation, open visits beyond traditional visit hours, knowing the person by person, physical touch, communicating with empathy, common courtesy communication, even to the delirious comatose patients, like introduction and explanation of what is about to happen, permission to touch, even for a delirious comatose patient is needed. Attending promptly to patient needs, individualizing communication modalities, giving patients some control of their environment, using eyeglasses, hearing aids, dentures, personal hygiene, all to be taken care of. All together constitute humanizing behaviors. According to Paul Mahajan, Voices from ICU, Perspectives of Humanization in Critical Care Settings in Indian Journal of Critical Care Medicine 2024 article, some of the aspects of humanization versus dehumanization, these are all real life discussions where communication aspect, infrastructure aspect, experience of care aspect. Communication, they properly greeted the patient with gentle touch. This is a good humanization practice. The doctors should try to understand the worries. They should explain the things in layman language. These are all dehumanization regarding communication. Infrastructure, we were allowed inside the ICU, and my father was super comfortable. I am grateful for that. This is a humanization, whereas dehumanization include we had to go up and down for half an hour to find the place. This place is quite cumbersome. All these are examples of perspective of humanization. Further, there is sub themes are divided in particular dimensions. Communication includes verbal, non-verbal. Experience of care includes physical care, care plan, emotional care. Infrastructures include building and environment. Autonomy. Example for a dehumanization approach is not asking permission before examination, side postural change, or physiotherapy. This comes under dehumanization in autonomy dimension. Even non-verbal communication plays an important role. If the doctors taking rushing sounds, making fleeting eye contact without any fixed eye contact while family members are talking, so many documents to sign, these are all come under non-verbal components. Doctors showing least interest on knowing the patient as a person, these all come under dehumanization dimension. Coming to good humanization practices, non-verbal nursing staff greeting with a smile, courtesy procedures performed as how the patient is doing, any discomfort, positive vibes when the doctor is around, verbal explaining the situation, answering queries in detail, talking about the prognosis, nursing staff even helping solving the issues of relatives. These are all come under good humanization practices in the communication dimension. Coming to environment, open visitation policy is considered as a good humanization dimension. Can we measure ICU humanizing by we can to an extent measure by using metrics like patient-centric outcomes, clinical outcomes, staff-centric outcomes, family-centric outcomes. Patient-centric outcomes by finding the patient satisfaction through surveys, mental well-being, finding out post-traumatic stress disorder, monitoring and follow-up. Clinical outcomes like mortality, morbidity, length of the stay. Family-centric outcomes, taking a survey from family satisfaction regarding during stay and even post discharge. Staff centric outcome keep on tracking for burnout, job satisfaction levels. HUICU has proposed a plan for humanizing intensive care. How to humanize? This is a spoke model where open communication between patient and family focus on well-being, better management, humanized approach, more dignified end-of-life care, flexible visiting hours. Open door ICU communication, all these come under plan of HUIC, Autonomous Community of Madrid. Can technology help in humanization or dehumanization? We'll come regarding it. The integration of digital tools and information systems can enhance the ICU experience. Clinical information systems demonstrated a decrease in documentation time so that the healthcare staff can spend more on the patient care and family interaction. Implementing dashboards to display discomfort zone can remind the staff to prioritize patient comfort. This digital transformation not only improves operational efficiency but also help in family-centered approach to the care. These are some of technology. My ICU Voice, an app designed where a patient who is on ventilator or intubated, not able to talk, can simply touch an iPad where there are various commands like I am not feeling well, I am feeling hungry, I am feeling pain. They directly touch over the iPad and try to communicate. This is a ICU Voice app. Electronic health records, EMRs, these digital tools streamline patient information among the healthcare providers and provide up-to-date data for informed decisions. Telehealth, video conferencing, all the we have done and made these are successful to an extent during COVID times. Digital ICU diaries, we will come in a short time. This is a voice app where the older woman on tube is trying to communicate through touch interface on the iPad. Coming to digital ICU diaries, this is an example of post ICU, the journal for tomorrow. The implementation of digital diary includes a person-centered ICU policy. Decreases it has shown to have reduced post-intensive care syndrome family entities. However, according to Hakma et al., some nurses have found it is non-user friendly. There is a lack of time and there is hesitance to write short messages. Coming to virtual reality and augmented reality, virtual reality rehabilitation in cardiac intensive care improves exercise capacity, mobility scale, ICU stay, and intubation days. Virtual reality found to have decreasing anxiety, stress, fear, and pain for the patient. It also help in mobilization and rehabilitation. The systemic literature search found 54 studies regarding virtual reality and augmented reality. Varied studies, randomized control trials, observational studies, case series. They have found that virtual reality can assist the patient relatives and healthcare in proper communication during and after ICU stay. It can help in traditional distracting or entertaining the patient and healthcare providers during intensive care. ICU patients should always can try to adapt these new technologies. Some of the studies have found regarding patient aspects, family aspects, healthcare provider aspects. Patient virtual reality to an extent help in distracting patient during critical therapy, during treatment, to eliminate rehabilitation, to enhance the rehabilitation during critical care therapy, providing information during and after treatment. For family members, it helps in informing the family or relatives regarding the critical therapy, establishing virtual rounds. Similarly, healthcare providers, it helps in relaxing to an extent, providing virtual rounds. Coming to benefits of humanization is considered to be a best evidence practice, avoids undesirable consequences, improves outcome, length of stay, quality of life, defines quality of care, improves patient experiences, improves family experience, considered to be depending on shared goals and values, multidisciplinary collaboration, satisfaction, team working, mutual satisfaction, person-centered leadership. Challenges while implementing humanization in ICU include there is a limited time for meaningful emotional engagement in a busy ICU setup. Sometimes staff may feel burnout and emotional fatigue. If the insufficient number of healthcare personnel, their policies such as open visitation policy may be difficult. Psychological and emotional needs can be overshadowed if we are heavily reliant on technology rather than going to the bedside of the patient. This is all to an extent a summary where patient-centered care, family care, healthcare providers, environmental redesigning all together helps in humanizing ICU. Always minimize trauma, no restraint approach, musical therapy, greenery, ICU diaries, proper communication. If patient is not able to communicate, iPad or tablets, eye tracking devices to an extent, always prevent to post intensive care syndrome, liberation bundle A to F, add GHA, gaining values and preferences, home-like environment, holistic care, interactive environment by virtual therapy, augmented reality, even pet visits. Family always needs priority, open visitation 24/7 without restrictions, family participation in care, supporting psychological consultation, social worker connection even for the families. Staff well-being, early recognition of burnout, training for communication, training for education, environmental redesign, we have already discussed. Technology and innovation, we have already discussed, like music therapy, animal assisted VR, AI-powered alarm systems, metrics to an extent. Policy making, humanization should be given proper accreditation, research funding for more humanization studies, continuous quality improvement is needed. Overall, holistic approaches to care, humanization necessitates a holistic approach that encompasses physical, psychological, and social needs of not only patients but also families and healthcare professionals. Acknowledging patient as a complex being rather than a single entity or a biological entity is crucial for implementing human practices within the ICU environment. Humanization, in short, is empathy, dignity, and holistic care. In the ICU, we save lives, but we must also nurture the human spirit. Thank you.
Thank you, Krishna. This is a very apt, crisp, and comprehensive recap of what humanization actually means. In fact, the next critique, the Chennai critique, the theme itself is humanization in the era of data science. And I think you started off well by giving a template on what all we can focus on when we work on this concept. Data science is something which is going to happen and which everyone has to learn and has to accept as part of medical profession going forward. But it doesn't mean that we just look at numbers, images, and figures and make a decision on the patient. We need to understand what the patient actually needs and what the patient actually wants, which should be done in a way which is acceptable to the patient, protects his or her dignity or their dignity, and gives the family a sense of belief that the professional who is treating the patient understands all these aspects. That is where humanization of intensive care comes into the picture. More data should not make us increase the distance with our patients. More data should be able to give us a more personalized prescription to the patient, at the same time bring in more compassion, more direct connect with the patient, and probably more transparency, because we will be able to give them more pros and cons related to the treatment plan which we have made for this patient. And this humanization is not only restricted to doctors. Everybody who has a touch point with the patient, the housekeeping, the security, the respiratory therapist, the radiographers, the sonologists, the nurses, the managers, and of course, ultimately the administration, they all have to understand that these patients are vulnerable and they need to have a humanized approach. To the summary of what Krishna has spoken. Ghanshyam, you want to add something?
Uh, Thank you, Krishna. Uh, I think what we are seeing is a reflection of what's happening in the society, right? That is extending to the hospitals, to the intensive care units. What complicates the things is many of the patients who are going through this do not have the control or are not to choose what they want. Well, yes, you have highlighted the importance of infrastructure and modern amenities which can make or which can help humanize the ICU. But if we look back for a long, long time, none of the ICUs had that kind of an advanced infrastructure. What people relied back then was on a constant communication between the doctor, with the patient and the families. So even if you are working in an ICU where you do not have the infrastructure which can help you with all those things, your simple gestures, your simple communication, your simply going and holding the patient's hands, spending that extra few minutes with the patient's families can mean a lot and can add that human value to the whole idea of ICU. That's the only thing I just want to add.
Yeah.
So
Think,
don't wait for infrastructural changes to happen. It may not happen.
it's a good point, Ghanshyam. Whatever happens in the society happens in our place of work also. If you look at people in the society, where is your son? Is in Detroit. Where is your daughter? She is in Alabama. Where are you? I'm in an old age home. This is what is happening in the community. So we have to get into that frame of mind and think about the patients who come into it. So thank you all for joining us today. And we will have, and if there are any queries and comments related to this program, please do post them on the group from which where you got this lead from, and we will reply as soon as possible. Please do join us again next week for another session on the HICS platform. Subscribe to the YouTube channel and please do register for the 10th HICS program in June, on June 19th to 22nd. Thank you very much and have a good day.
Thank you.
Thanks.
Hello.